Thank you all for joining us. With LifeCenter Northwest, this is our newly created End the Wait Advisory Group. So this is a conversation that has been happening for many years at LifeCenter, and we are so excited that you are able to join us and really launch our first meeting as part of the advisory group. We're really looking forward to having great conversations with each of you. A little bit of background briefly on what the advisory group is. This, of course, differs a little bit from our and the wait roundtables that I'm sure many of you have been participating in. It was Life Center's intention and goal to really identify some highly engaged hospital partners that could provide us with some feedback and insight into initiatives that Life Center is working on, process change and improvement that Life Center is working on, etc. And so as we reached out to our colleagues in hospital development, each of them had identified you as highly engaged hospital partners that they thought would be able to provide great conversation with us as we move forward to, of course, save more lives. So thank you for taking the time to join us today. We're really grateful that you're here. And I will go ahead and start with some introductions. I see there are quite a few of us on today, but if you don't mind sharing your name, your title, what hospital partner you are joining us from, and maybe what you're hoping to get out of this End the Wait Advisory Group, that would be great. I will start and introduce myself. I am Mallory Wood. I'm a Senior Hospital Development Program Manager, and I have the pleasure of supporting all of our hospitals in Central Montana. And I will pass to Justin Frank next. And then Justin, if you could call the next person, that'd be great.
Sure. Hi, everybody. My name is Justin Frank. I'm a hospital development manager here at LifeCenter Northwest, and I oversee our staff in Montana, Alaska, and the north sound of Western Washington. And I've been here at LifeCenter for 10 years this month. So it's been a nice journey, and it's great to see this finally coming to fruition. I'm really hoping to get some really great dialogue and insights from all of you as people who've been really engaged with your hospital's donation programs that we can extrapolate and sort of expand out to the larger service area we support, and also find opportunities to engage you all in ways that you would like to feel more meaningfully engaged with the donation process, either at your hospital or within our service area. So I'm really excited you guys are all here. Rachel, you want to go next?
Sure. So my name is Rachel Hauk, and I'm the Director of Hospital Development at Life Center, and I also oversee the family support team. Just recently started doing that. I, like Justin and Mallory, am really thankful for all of you being here and your time. And I would say, similar to what Justin said, I want to get out of this group of just having really good connections with our hospitals. We at Life Center spend a lot of time in hospitals, but we are not employed by hospitals. So we know that there are certain things that we may not um, see or we may overlook that you all could actually add and help us be more effective in our work together to save more lives through donation. So I will call on the next person, and then I guess we'll just continue to have people call on people until they're done. So Melvin, if you could introduce yourself and tell us what you're hoping to get out of it, that would be great.
Yeah, hello everyone. My name is Melvin Tam, nurse manager of the Burn In Pediatric Trauma ICU at Harvey Medical Center. Looking forward to working with the group, hoping to continue to improve our program here at Harborview, as well as network with the people across this network here, and always trying to strive to be our best here. So, and I will pass this to Kelly Green. Okay. Let's see. It looks like I may not be there. I will push this towards. I see Lee Edwin Edwin Lee on the screen next to me.
Hi, I'm one of the intensivists here at Providence in Anchorage, Alaska. And yeah, I'm just helping to kind of serve as a liaison and smooth out things, especially with the changes. And I'm assuming I just read whoever's on the list next. I guess Brandy Cornwell.
Yeah, so I'm Brandy Cornwell. I work here at Benefits Health System in Great Falls, Montana. I am the manager of surgical services and endoscopy, and play a very large role here in our organization as a donor champion, if you will, and run the program here.
And what are you hoping to get out of this, Brandy?
I guess to see what everybody else does, kind of best practices, see where we can tap into resources to work on areas that we may be struggling with internally. Sorry, am I supposed to announce the next one? Because mine is jumbled over here. So
That's okay.
No worries. I can help you with that, Brandy. Thank
thanks,
you.
Mallory.
Sure. Rose, would you like to go next?
I can go next. My name is Rose Atkins. I'm the Director of Inpatient Services at MultiCare Auburn Medical Center in Auburn, Washington. We are a small facility. I have 81 inpatient beds and a 16-bed ICU. Been involved in this subject for about, 25 years. All the way since I worked in Arizona and then came to Washington. And exciting stuff happening here at Little Auburn today. We have a DCD case in the OR right now. So Mallory, if you can send it off to the next person.
Absolutely. Thanks for sharing, Rose. We hope your case goes well. Let's see, Michelle, would you be willing to go next?
Sure. My name is Michelle Didio. I'm the neuroclinical nurse specialist for Providence Swedish and serve all the hospitals in Providence Swedish system. I think from my standpoint and being involved in this, I've been a champion and really engaged with other facilities and systems that I've worked with LifeCenter Northwest as well. And I think I really like to help Swedish be an early adopter of some of the future initiatives to be able to move this forward.
We love that enthusiasm. Dr. Ding, would you be willing to go next?
Running out of cars. Okay. I don't mind waiting. Can't be dirtier than my car. I got 2 kids.
Okay, we'll come back to Dr. Ding in just a moment. Kim Ladner, would you be willing to go next?
Hello. Sorry, my camera is not working. Yes, so I am the quality manager here at Astoria Toppenish Hospital in Toppenish, Washington, just outside of Yakima. We are a rural hospital with 65 licensed beds, which we currently utilize about 16 of those due to staffing challenges. We do not have very many referrals, but we want to make sure that the ones that we are doing, that we're getting those referrals done quickly and in a timely manner. So we had a couple of fallouts last year, so just really working to make sure that we are getting those referrals to you guys in that timely manner and making sure that we're doing the best that we can with them.
Awesome, thank you. I'm Jen Moyes.
Hey, so I'm Jen Moyes. I live up in Bellingham, Washington, so I'm with Peace Health St. Joseph Medical Center, and my role is a nursing director of critical care services. And I think I picked this role up being the liaison with our organ donation program probably about 7 years ago. And I've learned a lot. and so I'm hoping to continue to learn and to help others be able to learn from what we've done here, and really just to say, how do you take a program and really embed it inside the organization so it's owned by your frontline caregivers or employees, and that once I manage to get to that point, I'll know we have arrived.
I love that. I think that'll be a common theme probably across many of our hospitals. Okay, Dr. Ding, would you be willing to share?
Sorry, guys. I'm at the car dealership. Can I go last?
Yes, of course. I'll come back to you in just a few moments. Thank you. Okay, Bevan, would you be willing to share?
Hey, good morning. My name is Bevan Stevens, and I am the senior nurse manager for our small intensive care unit here at Fairbanks Memorial Hospital. I think that I've been involved with LifeCenter Northwest in some capacity ever since I've been a nurse. And I have to say that these kinds of patients, these scenarios are my absolute favorite to take care of. So I'm very passionate about the mission of organ donation. I am also very, very passionate about supporting our communities and our families. And so, I would say that um, most people probably agree that these types of things are the best thing to come out of an awful situation. But I do think there's some opportunities for us to uh, just improve some things, let's say. One of them being our medical record system is giving us some fits right now, and in terms of how we handle these cases. And certainly, I think, Mallory, the thing that I've spoken with you most recently about with our recent case is just, the level of family support that we have from LifeCenter Northwest, the liaison person. That seems to be two opportunities for us. What I hope to get out of today, I am double booked, so I'm probably gonna have to jump off early. I'm so sorry, but just I think making the connections and seeing how other people do things. I really appreciate the networking. Thank you.
And thank you, Bevan. Let's see here. So I'm going down my list. Teresa Montoya.
Good morning. My name is Teresa Montoya. I'm the Director of Critical Care and Respiratory Therapy Services at St. Joe's Medical Center in Tacoma. I'm just hoping to do some networking and look at really just trying to ingrain this program into the hospital. Like many places, we're kind of rebuilding after our COVID, and with lots of new people, lots of new faces. So almost having to step back and kind of start over. So looking at how to build it from the ground up again.
Awesome, thank you. And Reese, are you able to share?
Yeah, absolutely, Mallory. Hi, my name is Reese Hayden. I'm a senior communications specialist here at LifeCenter Northwest. Most of you have probably been bugged by many emails from me over the last few years, but I help to administer our and the Wait campaign from a communications and design and those types of perspectives. So just here today to listen to the conversation and to help to make and the Wait as good as it can possibly be. I did want to say, I know someone spoke up earlier about having to duck out. If that is the case for anybody else or any other colleagues of yours who are hoping to be here today but can't make it, this is being recorded and we will make it available to folks to share the video recording of this after the meeting.
Awesome, thank you, Reese. And yes, you also see me kind of coming on and off mute as I'm also taking minutes that we'll provide to you following the meeting as well. And then I see Dr. Ding, are you available at this moment? Okay, we'll come back to Dr. Ding in a few moments. Is there anyone else that I may have missed on the list?
Well, we can get Dr. Ding's impression, but I can just share that Dr. Ding is a trauma intensivist at Providence Regional Medical Center in Everett. So she works on the SICU at that hospital and is a great partner there.
And thanks, Justin. All right, well, thanks everyone for sharing. I definitely see some common themes across the conversation already, which is exciting. And so now I'll pass it over to Rachel to talk a little bit about what the intentions of this group are and some of the conversations we anticipate having this year.
Yeah, thank you, Mallory. And thanks everyone for sharing kind of what you're hoping to get out of the group. As we talked about, we really wanted to bring this group together as an advisory group for our In the Wait campaign, which is now entering its third year. So the In the Wait campaign was an idea that we had really trying to eliminate deaths on our local waiting list. We know you all have probably heard me say it many times, like we don't think we can end all deaths on the waiting list across the entire country, but we can certainly do more to impact our local waiting list. And so we wanted to partner with our hospitals, big, small, medium, whatever, and we have representation from all levels here today. And that was by design because we know one thing that I've learned over the many years of working in donation is that all hospitals are different, but all hospitals are hospitals. I don't care if it's Fairbanks, Alaska or downtown Seattle. They all have doctors, nurses, their own sort of challenges with staffing, patients, all of that. So really wanted to bring a collective group together to sort of have more insight from the folks inside the walls of the hospitals and that we could really bounce ideas off this group to be more effective going forward. And just to give kind of a quick overview of like the historical context of End the Wait and how we arrived at our three main objectives, you all have heard them many times. There's three. There's eliminating early extubations, there's honoring donor decisions, and then more recently, it's the connecting with families. Um, so I think a couple of years ago, we decided to get very basic in terms of the things we were trying to address. We know there are many, many things within the donation process that we could address, but there's certain ones that would contribute more readily to the success of the donation process. The first one being the extubations. Everybody knows if a patient's extubated, they cannot be a donor. So by eliminating early extubations, we by design increase the opportunity for donation. So that was very basic, but also something that's critically important for donation to move forward. The second group of things that we looked at was really that authorization piece. And there's sort of two buckets within that. There's the patient themselves authorized donation, and that's those the registered donors, which I think we're going to talk more about today. We've been talking a lot about that in the last 6 months. Um, but, we could have a conversation, and many people have had conversations about if every person knows exactly what they signed up for, if every person should have had to make that decision at the DMV. And really, we're not going to solve for that in this group. But what we can know is that at some point, that individual was asked the question, would you want to donate and save a life? And they said yes. So that is by the UAGA, an authorized donor. So we want to move forward with any authorized donor that we can. So that's the work that we've been doing to really increase those numbers of patients that are registered that we do move forward on. And the second set of authorizations that we're looking at is really those next of kin. If the patient themselves hasn't authorized donation, we want to be able to talk to that family. And what we know also is that most people generally, if you talk to them on the street at 10:19 in the morning on a Tuesday, would say, yeah, I would want to save a life, or I'd want my family member to save a life if they could. But most of the time, we're not talking to them on an average Tuesday morning. We're talking to them when they're experiencing traumatic loss, they're out of their comfort zone in that fight, flight, or freeze scenario. So really that piece of connecting with families is identifying the appropriate time to connect with the family so that they can be empowered to plan their end of life decisions in a way that donation can be part of that. And then also the appropriate training for our team and partnership with you to make sure we're helping them access that place of generosity, which is much more challenging to access when you're in that place of fight, flight, or freeze. So those are kind of the overarching themes that we've worked towards within the wait. And so you'll see that throughout. And each one of those different objectives has different processes that we would want your feedback on. And I think our primary focus today is honoring donor decisions, but I'm sure within this group, we'll touch on all three of them over the course of the time that we're together in the coming months. So that's kind of the background. And now I think I'm handing it over to either Mallory or Justin. I'm not sure who is going next.
Awesome. Thanks, Rachel. I will pause there and see if there are any kind of immediate questions that you guys have before we jump forward. Okay, perfect. I see you're back on. Dr. Ding, would you be willing to do a brief introduction?
Yeah, hey, thanks, Justin, for pinch hitting for me there. My check engine light came on this morning, so it was terrible. I'm Linda Ding. I'm one of the trauma and critical care surgeons at Providence in Everett. So I've been with the group for about 3 years now. I trained in upstate New York, Western New York in Rochester. So I worked a lot during residency with the Finger Lakes OPO there. So, I have a passion in, sort of palliative care ethics and end of life in the ICU, the ICU work that I do. So I guess I'm just here. I don't like to reinvent the wheel, so I'm just here for the good ideas, so I can bring them home to my institution. Thanks, everyone.
Awesome. Thank you. All right, so I'm going to briefly share the charter that we sent via email last Friday. So if you have an interest in pulling that up yourself, you're more than welcome to. Otherwise, I am going to share my screen so you can see it real quickly. All right. Move my screen over there. Okay, can you see this all right?
Yep.
So thank you. All right, so this again is our End the Wait Advisory Group charter. So we did want to acknowledge that this is a separate advisory group from, of course, our LifeCenter advisory group and our governing board. So this group is specific to help our hospital development department with key initiatives that we're working on, our End the Wait campaign, and of course to collaborate, which sounds like many of you are interested in doing, kind of networking across our service area. So certainly our purpose is to get your insight, advice, and feedback on the many different things LifeCenter is currently working on and anticipates working on throughout the next few years as we move forward to honor more donor decisions. Our time commitment that we are asking for is to meet on a quarterly basis unless the group does determine otherwise. So if, for example, a specific topic comes up that maybe certain members are interested in meeting and talking more about, we are certainly happy to help foster that environment and can do that kind of according to that group's wishes. But as far as the base kind of requirement we're asking for with the advisory group is to meet on that quarterly basis and to hopefully have our participants be able to attend 3 of the 4 meetings. So again, all of these meetings will be recorded, as well as minutes will be provided, and all of the program managers that support your hospitals will also be looped in so they are aware of kind of what's progressing through this advisory group as well. As you can see, of course, our meetings will always be virtual since we are across a wide range of a service area, all the way from Alaska to over here in Montana. So they will continue to be virtual and likely on Teams unless anybody has any strong recommendations for another platform. And then we did include a list of all of the members joining. So if you do see any discrepancies with your title or preferred spelling of names, please let me know and I'm happy to update that accordingly as well. So this is available to you. I will also include it to the meeting minutes today for you to be able to review as well. Are there any initial questions on kind of the intention in that charter? All right, well, I'm going to pass to Justin to start getting into the deeper conversation of honoring donor decisions.
Thanks, Mallory. So most of you are probably really familiar, and we've had lots of conversations both in our roundtables and probably with our partners directly around the work to honor all registered patients. And we've been working on this incrementally going back over the last 2 years. Last year, we started escalating cases beyond just brain death declared patients to those who are appearing areflexic and haven't been declared. And starting April 3rd, the practice change will continue to evolve where we'll be escalating cases where registered patients who are DCD candidates maybe have family opposed to donation for whatever reason. So today we wanted to sort of just share like what's happening and when and why is it happening. And Rachel sort of alluded to this already a little bit. So starting April 3rd, we are going to start escalating in addition to what we've already been doing within the hospital any case situations where we're either seeing potential opposition or actual opposition to moving forward with donation on any candidate for solid organ donation. That would include DCD, which is the major practice shift. The reason we're doing this is obvious. I think we're trying to both honor patient autonomy and their own individual decisions while also maximizing the opportunity to save lives through organ donation. But we recognize that this is a change and will have impacts on the healthcare process for you and for your colleagues on the ICU and in the emergency departments, as well as potentially the OR as well. So I wanted to walk through real quickly sort of what this would sort of look like, because I think initially, both internally at LifeCenter and within our hospitals, there's sort of this worst case scenario reaction to how this would work that, starting April 3rd, every single registered patient, no matter what's going on in any scenario, is going to move forward. We're going to be asking for cases to be delayed days and days, and we're going to be steamrolling through that process regardless of what anyone thinks. And that just definitely is not the case. We want to make sure we're really clear with our intentions of what we're hoping to do starting April 3rd. So the main change is that, of course, we want to try and move forward with every patient that is registered. That is our goal. And we do believe strongly that patient autonomy, both backed by the conditions of participation and state law in all of the states in our region, really reinforces that need and requirement. Having said that, I think additionally our goal is to, from that point on, once we've tried, is to escalate within the hospital based on whatever process or chain of command that you want us to go through within your hospital system. And I know it's set up differently at each individual institution, but our goal is to slow things down, get people together, and have a conversation about how to proceed going forward. And I think at the end of the day, as much as we do want to move forward with every single case, we require the partnership and support of the hospital for that to work. So state law is really clear. Conditions of participation from CMS and Joint Commission and DMV are really clear, but these are really complex cases, and I think whether it's timing or other reasons that come into play, it's going to be a case by case basis where we're trying to figure out what the best path forward is going to look like. So I wanted to break this down real quickly into two different scenarios from a perspective of what this would look like. One is a timing based decline and then everything else. So I'm going to start with the everything else. So in most scenarios where families are opposed to donation, whether it's DCD, brain death, or anything in between, if it's family is just opposed to that donation process or moving forward donation for whatever reason, what we typically would want the hospital to do is slow things down so that the family can process what's going on, so that we can huddle together as both the OPO and the hospital to identify the best path forward, to give the family, like I said, time to process this information and come to, at the very least, terms of understanding of how this would work, but also to navigate whatever barriers that might be there if we can address those. So slowing the process down is the key piece of this. And I think that is true, again, like we've been doing already in brain dead cases, would be true as well in DCD cases. Having said that, our number one decline we see in registered DCDs that don't move forward is due to timing. And a lot of this comes into play because of when we're speaking to families, and we can jump into that conversation of how we're trying to mitigate opposition to begin with by having more timely family conversations. But generally, what our goal is relatively similar with a twist. So again, we want to slow that process down. As Rachel mentioned, if a patient is extubated, there is no option of donation. But at the same time, the UAGA is really specific about, or not specific, but they use very intentional language around hospitals needing to provide a reasonable amount of time for the OPO to do evaluation and placement and coordinate for donations, so that once that patient does pass away, we can do our recovery and honor that patient decision. So what we're really hoping to do, and a lot of OPOs have not defined what reasonable means, but we're hoping to have an altruistic goal of trying to do this quickly. So the idea of making families wait days and days is not what our intention is. Our goal is to huddle with the hospital, whoever the appropriate decision makers are, and figure out how to best address that timing concern. And in most places in our region, our goal is going to be to try and target a 12-hour window. We have a rapid response team we're putting together that will be rolling out here later this month. And we're really hopeful and optimistic that in these scenarios where we can identify situations early and quickly, that we can hopefully address that timing concern and overcome those, both with timely conversations and with moving more quickly to try and go to the OR. Having said that, obviously that will require that partnership and collaboration with the hospital. And sometimes it'll go outside of that 12 hours, but we're not going to be making families wait days and days. And there are going to be scenarios where either the hospital or LifeCenter or both make a decision to not pursue donation. So I think I want to be going back to my intention of like, our goal not being to steamroll every single case regardless of scenario, and not be considerate of hospital scenarios and family scenarios. That is absolutely not our goal. But I do want to call out that our goal is to move forward. And so I guess I want to stop there. I've provided a good amount of information of sort of how this could look like, and see what, from your perspective, are your biggest concerns. And I know we've provided some resources already to hospitals. We're going to have more FAQs to come out. We've provided sample escalation protocols and policy language, and I know a lot of hospitals have worked to do that. But generally, I think what we would really appreciate from a feedback perspective from this group is, what are we missing? What is the opportunity to help hospitals be more prepared for this, knowing that these are really challenging scenarios?
Hi, this is Teresa from St. Joe's. Can you speak more to the 12-hour? I kind of got a little bit lost in there. What the goal of 12 hours from when?
Yeah, that's a great question. So first off, the UAGA doesn't put a specific time on anything. Like I said, there are some OPOs that determine reasonable amount of time is the time it takes to do donation, whatever that looks like, in the most expeditious fashion possible. LifeCenter knows with our service area that that could be a little unreasonable to our hospitals, and we want to set a bit of a higher standard, a higher goal. So our goal internally is to try and proceed within 12 hours of families expressing opposition to LifeCenter Northwest.
Okay.
So that would be the imaginary timer start time, if you will. Having said that, and our internal counsel has been really clear about this, there may be scenarios where we need to go a little outside of that. Delays happen, whether it's trying to get things set up for the OR, people traveling in from out of town, family challenges or situations, staffing issues, either at the hospital or with LifeCenter. And so I think there is we do want to have a collaborative approach to this and have some flexibility, but our goal is to move forward within 12 hours. And, will we go to 13 or 15 sometime? Maybe, yeah, that might be what we're asking for. But I think generally what we won't be doing is asking for 2 days if that's something that the family and the hospital aren't able to do. Is that more clear, Teresa?
Yeah, thank you.
Yeah. I think one of the biggest things that's come up in our conversations that we've had internally and externally to some extent is how this changes the dynamic for the care team and how end of life conversations are presented and how you manage families' expectations with regards to next steps and things of that nature. I'm curious if there's any feedback or thoughts around that context.
Yeah, Justin, this is Linda Ding from Prov Everett. So yeah, what you said about managing expectations, I think is really important. And I noticed that, well, just the bedside nurse helping in managing expectations, I think is tremendous and often underappreciated. And so at Providence, I'm sure this is everywhere, but we have so many new nurses, so many travelers. They don't know the hospital policy. So I've been trying to assemble like a module of educational materials because I think the new nurses and the travelers don't always get a standard set of orientation experiences, and certainly they have so many other things to orient to. And I'm sure what our objectives are one of the last on their agenda. So I've been talking to the nurse manager and just saying, would it be helpful to put together something like that? So I'm if anyone else has pre-made things that they want to share, that would be great. But I was going to at least start chipping away at that over here.
Dr. Ding, that's excellent to hear, and I think that's something we would love to lean in and help support you in if you're open to that. I know we've actually created in the goal of doing sort of an education blitz here over the next few months. We've created some standardized presentations that we can provide to any members of the care team at any point. I think I might even be presenting in some degree to the MICU staff on Thursday morning. So my point, I guess, is if there's an opportunity for us to support you in that, I think we're welcome to do that. Pre-COVID, I think we were involved in all the traveler and new nurse orientations for the ICUs. And I think that's something that we would love to revisit, not just at Prov Everett, but at any hospital if there's a need to support additional training and education as we move towards this process change. Jen, you have your hand up?
I do, because I think the other thing to tag in behind that, one of the things we realized was, as we dealt with travelers and new nurses, it was physicians. And as we would bring in locums, and that would be where my fallouts would be, is really saying, how do we close the gap with our locums or my new hires that I was bringing in? And so that was another component that we really have worked on to really say, how do we really bring that knowledge level up and say, this is our practice inside of the hospital?
Yeah, I think that's a really good call out. This is multidisciplinary and affects more than just the bedside nurse for certain. In fact, Jen, I had a meeting with the new physician at Bellingham last week. I was covering for a sick employee. So good conversation was had definitely about that, at least at the fringe level. And we're happy to go more in depth, either as a onboarding process or as we roll this new process change out for appropriate staff that are going to be impacted by this. And I think, to be clear, this will impact staff in the emergency department, ICUs, and potentially the OR if we're looking at rapid cases where we need to go to the OR quickly. Michelle, you have your hand up?
Yeah, thank you. I think one of the other things too that is integral, and we talk with our hospital development person all the time. I look like I'm frozen. If I am,
We can
I
hear you.
apologize. Okay. The is the some of the work, and I look forward to be able to see how it's growing within LifeCenter, is your work in, because we've really worked to move our referral process to early referrals, because the earlier that we can refer, the earlier that you can talk to families, the more that families can come to a family meeting with all of their options, minimize any possibility of inadvertent requesting by healthcare providers, and giving them the opportunity to minimize that boomerang experience or stress of having a withdrawal of life support conversation, and then LifeCenter comes in and says, oh, here's another option. So moving that to the forefront of that conversation matters greatly for us within the system. And so I think, as some of your early contact, the earlier that LifeCenter can be in contact with families, makes the ability for rapid DCD donation and coordination at all levels really possible. So I know that that matters for us as well. So I look forward to hearing how that grows as well.
Yeah, I think you're calling out a really integral strategy that we're trying to implement in addition to the early referral is, and many of you may be familiar with this or maybe even been involved with this, but we've always done a really initial and ongoing clinical review of what's going on with a patient, but we've started over the last 6 or 8 months really diving into doing family readiness assessment and really assessing where that family is at. In the past, we would wait, as you would call out, Michelle, for that family to make an end of life decision. Have they decided to move towards palliative extubation or not? And that determines whether we move in to speak with that family at that time or not. And now what we're seeing and what we've seen from the data generally is that families often or more often than not are telling us, we support donation. We wish you would have talked to us yesterday or 2 days ago and we would have totally done this, but now we're done. So what we implemented and started doing, and Rachel can add to this, she's overseen it way more in depth than I have, is as we check in daily with the bedside nurse or provider, we are doing these readiness assessments about key indicating questions about what's going on with that family's picture. And I think maybe what we can do, Mallory, is we can send out to the group like what those questions are so that if you guys have additional questions we should be considering, feel free to pass those along to us. But we're trying to figure out is if there's a yes, should we be talking to that family sooner? Are they starting to make end of life decisions? Are they bringing family in from out of town? Are they gathering at the bedside? Have they changed code status? These little indicators tell us that the family's starting to grasp what's going on. And Rachel, you can probably quote the data better than I have, but we've seen tremendous improvements in authorization outcomes, both in registered and non-registered. And what we're hoping comes from this is multiple things. Obviously, preventing oppositions to registered patients is one, but also improving authorizations. And also, I know Dr. Ding and Dr. Lee will probably appreciate this, is not putting you guys in a position where you're providing end of life decisions and there's no idea of what's going to happen next or when, instead of like having a collaborative plan that's moving organically through where that family's at that moment. Rachel, I don't know if you want to add more to that.
Yeah, I would just add that this is a great place to sort of highlight the overlapping nature of the three objectives for the In the Wait campaign. And to Justin's point, we've seen really, really good results with these earlier, and I would actually call them more timely conversations, not necessarily early. The other thing, I was just looking at data this morning related to our donor registry opposition data last year compared to this year. And so we look at it, the rate, we call it the rate of donor registry opposition to the registered potential. So we want to make it a percentage, because if we just look at raw numbers, our potential goes up and down, as you can imagine. Last year, our rate of donor registry opposition to registered potential was 15%. And for this first quarter so far, we are at 7.7%. And that's with our new process in terms of, talking to families in a more timely manner, and really focusing on some of these strategies to help lower the resistance of the families. The one thing I would love to get thoughts on from this group, and maybe suggestions, is sometimes we do get pushback from the healthcare teams of thinking like sort of that they're very used to the process to where we wait until the family has actually fully decided and voiced, like, yes, we want to withdraw support today at 4 o'clock. And that, has traditionally been when we've talked to families. And so sometimes now we're getting healthcare teams that would be like, no, 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 you need to wait till they make more decisions. We don't think this is the right time. So I'm just curious from the group's perspective, if there's things we could be doing up front, if there's better conversations that we could have to help make sure that we're really hitting that timing versus sort of that, inertia that we've always done it this way, so we should continue to do it this way. And to your question, Teresa, we can absolutely share the questions 100%. I can even get them and put them in the chat right now while we're discussing.
I'm typing them in there right now.
Dr. Lee, go ahead.
Yeah, just to clarify, so ideally, when would you guys want to, like, jump in to start the conversation?
Yeah, we look at Mallory will put in the questions. There's 5. The first 2 really get at just kind of what trajectory is the family taking. It's, have they made the patient DNR, and is there a palliative care consult or kind of end of life care discussion planned? Those 2 are really just like, which direction is the family leaning? And then the last 3 are much more specific. Are they gathering at the bedside? Have they discussed funeral arrangements? I'm trying to remember, maybe you can say what the other 3 are. Oh, she's just put them in. That'll help me. Let's see. Has the family indicated they understand the patient will not survive? So this is worded very specifically because sometimes, as you all know as physicians, you can tell a family that the patient's not going to survive. That doesn't mean that they understand it or accept it. So trying to get, are they making indications that they know this is non-survivable? Have they actually met with comfort care? Has withdrawal of life support been brought up? And so we're looking at those questions to really sort of get, does the family get it? Are they making end of life decisions? And then as soon as we understand that they do get it, then that's usually the right time to connect with them. If we get into the conversation and find out that they aren't getting it, that they're, still saying, no, he's going to wake up, we think so, then we would exit without bringing up donation. The other thing that we really look at in making a determination is there any indication that there is like mistrust between them and the healthcare team? Typically, if there's any of that, we would not go in and talk to a family, because that has a tendency to increase that mistrust, not decrease it. So that's one thing that we kind of have in the back of our mind, of always trying to assess, like, is there a mistrust for the healthcare team for whatever reason? Then we might hold off longer. But those are the kind of indicators that we're looking at.
I would just add also that while we have these indicators, it's entirely collaborative with the care team. And so to Rachel's question, we would never speak to the family early without, or timely, as we would put it, without having consensus from the care team that it is a good time and the right time to do it. But we want to better understand. And while we value the subjectivity and the context that you can bring, especially if we're not on site, with the family or around the hospital at that moment, but also just trying to see, like, making sure that there's clear understanding as to what we're trying to get at, so that we're taking down the barriers that could prevent an actual timely conversation.
Yeah, and I
I mean,
think to that point,
oh,
go ahead, Dr. Lee.
I mean, just to complete the thought, I think those are reasonable triggers, and frankly, I don't think it's early based upon those triggers. It seems pretty timely, and I think ultimately, the subjective part is just kind of reading the room, right? Just getting the sense of the family, which you won't know that you're going to have to rely on the bedside caregivers. So, anyways, I think it's very reasonable.
Kimberly, I think you have your hand up.
Yes, so something that a challenge that we have as well in our facility is we are actually located on the Yakima tribal nation. And so something for them is once there is a decease, they have the expectation that their family member is buried within 3 days. So that's something that we have to work through as well. That if we're working, have that potential concern that we're working with the family as soon as possible so that everything can be in place once that patient does demise.
Yeah, that's a really good call out. We work in a number of really unique and diverse areas in our service area, from Montana to Alaska, and even in parts of Washington, as you're calling out, Kim. And I think we always want to take those pieces into consideration, any cultural components, any timelines that may be affected. And if we know those things, having them in the back of our mind, while also giving that family or that patient the same sort of care and consideration we would give any patient in that moment at the same time. And so I think these are the kinds of things to think about when you're creating both less policy, but more protocol of how we navigate these. I know some of the protocols at hospitals that I've partnered with really look at early indicators of potential opposition. What are those boundaries or barriers that we'll need to navigate so that we can start thinking about that upfront in advance, as opposed to waiting till there's full on opposition to whatever's happening. So I think that's a really good call out. And I think anytime we can have that context, it helps us form a plan better with the care team.
What is your all's perspective in terms of how you feel like the frontline staff in the ICUs, particularly like the nursing staff, do you feel like they have um, understanding of this? How do you feel like they would respond to kind of this honoring donor decisions, and not necessarily like Justin mentioned that it's going to be a steamroll, but that we are going to slow down and we are going to take the steps to, involve potentially the attending, hospital administrators, nursing leadership, things like that. I'm curious what your thoughts are on the frontline staff.
I think for a lot of them, for them to, when this, because for where we're at in nursing, especially in the ICU right now, for the majority of nurses, it's their first time, right? Like going through this. Like we don't do this that often. Swedish, we have a high donation rate, and it's every nurse who's doing it is their first time, and so it's just where we're at. So I think from a communication standpoint, I think the one thing that really helps them, which I know we had a kind of a communication challenging case not too long ago, is knowing that their work and this process is leading to something, rather than leaving them feeling like they're in the middle of something that doesn't have an end, or doesn't have a direction, or doesn't have a goal, either for outcome or for the family. And so I think being able to make sure that ambiguity for them is minimized in that place, knowing that conversation at work has a goal, an outcome goal for them, I think really matters. And that communication being a priority when these cases do start, and as the program increases and ramps up, for that to be a high communication priority to the direct care nurse.
I think that's a great point.
I agree. Communication is always challenged when you have a lot of new people and a lot of variation of folks to get to. So I think in any way that we can streamline, this is what we're doing and why we're doing it, simple, that they'll know when they get that call from your team that's asking all these questions and they're going, why are they asking me all these questions? So we can put that picture together so they see it. I think she explained that very well. That's what I'd like to see.
Great.
Yeah, I'd also agree with what the group members are saying. I think we were very fortunate to actually have some of your team members round on needed stuff in the ICUs here at our at Harvey Medical Center, and we truly sometimes leveraged their expertise just because we do have a lot of new influx of nurses and a lot of contract laborers. But as long as someone on the team knows where to escalate and find answers, of course the managers and stuff are available here at the organization to help troubleshoot and stuff. But definitely early communication, early identification will definitely help out.
I'm curious from that same question for Dr. Ding and Dr. Lee too, just because I know for providers, it's not every provider, but I know some providers, it's like once donation starts, they're like, I'm done. Like they're your patient now, or it can feel a little different in those contexts. Like how can we best prepare providers and physicians for this change in sort of maybe what they're used to from a workflow perspective?
I'll be honest, it's not for me, the challenge is not so much on the front end, it's on the back end, especially with the DCDs. So I mean, I had a couple cases specifically where they did not end up donating. And we felt like it was the other way where, now what? The family had a lot of questions, and like Life Center it happened to be the weekend, and Life Center wasn't around to, follow up. And so frankly, to be honest, that's my concern. It's actually on the back end, not so much on the front end, because I don't see it changing our workflow or practice that much, at least, at our facility.
I think that's a good call out, and I think in cases of registered DCD potential opposition, we are going to be taking a more sort of narrow focus on what potential looks like, as opposed to being more aggressive with what we move forward with, for the exact fear of not wanting to try and minimize how many discontinued cases we have. And I think if you have more scenarios that pop up like that, Dr. Lee, talk to Lulu and we can figure out how to look into those cases specifically.
Yeah, during my time in Everett, we haven't, at least in the SICU, I don't think I've personally been involved in a case where there's been strong opposition, and we haven't had to utilize the process that we've laid out yet. I mean, fingers crossed. So, um, I'd like to think that's because we're doing a good job on the front end. But yeah, after, if there's sort of a, if the patient's not able to be a donor after a DCD, I think we've had those situations, although also rare. And again, I think sort of setting the expectation for both the provider and the nurses and the docs and the family early on is important. So on the off chance. But it sounds like if it was unexpected, that maybe like if you think, oh, there's going to be a successful DCD, sometimes it can't be predicted.
Yeah.
That's tough.
Well, I just want to thank everyone for the feedback. I know we're running low on time, and Mallory has a couple housekeeping items before we depart. But I do know we'll probably revisit this to some context in our next meeting, which will likely have had a couple months of this new sort of inclusion of DCDs into our plan to try and honor donor registry. So if you have more thoughts in between now and then, please pass them along. Otherwise, we'll plan to revisit this in some context in a few months.
Awesome, thank you. All right, well, we are going to take a moment just to go around individually to each of you quickly and see if you had any last thoughts or things you certainly want to make sure that I make note of to include in the minutes. I'll go ahead and start with you, Michelle.
No, that was all.
Brandy?
Nope, I'm good on my side.
Okay, Dr. Dean?
Nothing else to add. Thanks for the meeting, and nice to meet you, everyone.
Yes, and thank you for your recommendation on orientation. I have that included to follow up on as well. I would spend all day at colleges doing education if I could, so I have that on the list for sure. Susan, I know you were able to join about halfway through. I just wanted to check in with you.
Sorry for being late. Nothing to add. It sounds like really good work. Thank you.
No problem. Thanks for joining us today. Kim?
I don't have anything to add either. Thank you.
Dr. Lee?
Nope. Thank you.
Melvin?
Nothing to add. Thank you.
Great. Rose?
Nothing else. Thank you.
Okay. And Teresa?
Nothing else. Thank you.
I will include a follow-up, of course, with all of our meeting minutes, a recording of our meeting, and I'm going to also include those questions that we are doing with the earlier family initial donation conversations as well. So you have those. They were included in the chat, but I will have them separate as well. And then lastly, I did want to check in and see, we are looking to schedule our next meeting. If you have any specific dates and or days of the week that would absolutely not work for you, please follow up with me via email. You can respond to any of the emails I've already bothered you with, or the one that I'll be sending this week with all of the documents from today. And please let us know. Otherwise, we'll be sending out another poll to try to identify the best date in which we can all get together again to continue this conversation. All right. Well, thank you all for joining in the great conversation. Justin, Rachel, any final words in our last 3 minutes?
No, thanks for everyone's participation. It's been great.
Absolutely. All right. Thank you all.
Thank you.